是一场探寻幸福的旅程，一次欢聚，给予我们青春不散；一见钟情，给予我们一生守候；一路陪伴，给予我们圆满幸福；一次新生，给予我们更多爱的延伸。感谢生命的给予，一路如影随形，一番旖旎风光。但谁来给予生命悉心关照，为它阻挡风雨，铺洒阳光？赛生医药秉承以患者健康为己任的崇高使命，给予生命更多关爱、帮助及慰藉。立足中国本土，融合全球智慧，坚持自主研发与引进国际品质并行的服务理念，只为造福更多患者。同时，普惠中国及全球其他国家，让生命公平享有高质量的医疗服务和产品。以研发解码科技奥秘，以创新探索医疗未知，以严格质控体现价值，以卓越见证每一步飞跃。赛生成熟而充满智慧，让医疗释放持久能量，给予生命拥抱新生的力量。赛生年轻而充满活力，专注于重大及特殊疾病领域，给予生命重燃希望的可能。赛生更理解生命对健康的渴望，更懂得生命无法承受的病痛，更明白守护生命所肩负的责任和担当，更有能力给邂逅意外的生命以充盈生机的希望。赛生给生命以希望。
Okay. Okay. The time is okay. Let me start. Good morning, ladies and gentlemen. Welcome to attend the China-US Neuroblastoma multidisciplinary treatment webinar. I'm Professor Zhao, Zhao from Sun Yat-sen University Cancer Center. I'm glad to serve as China co-chair for this meeting. Neuroblastoma is a tumor originating from the sympathetic nervous system, and it's the most common coronary malignant solid tumor in children, with more than 90% of the neuroblastoma occurring in children under 10 years old. However, relative research is extremely lacking. Therefore, it is important to understand the disease characteristic, diagnostic, treatment, and the prognosis as much as possible in clinical practice. Today, we're glad we have a team of Chinese and American physicians to get together to share their perspective and treatment experience for curing this cancer. First, let me introduce China co-chair Professor Zhao Qiang, of Tianjin Medical University Cancer Institute and Hospital to give a welcome remark. So Professor Zhao, welcome, please.
Respected Professor Zhang Yizhuo and Professor Modak, Professor Laquilia, Professor Kathy. Good morning, good evening. And just as Professor Zhang has mentioned, neuroblastoma, especially for the high-risk ones, it is a very refractory malignant disease for children. And we all know that when a child is diagnosed with this disease, not only very harmful to the patient, him or herself, but also to the whole family. So we have multiple ways to treat, including surgery, chemotherapy, immunotherapy. Well, in many cases, there is a group of doctors together with the family members to give the health care, to give the treatment and care to the child. So I'm so glad that today we have not only one group, but groups from both China and the US for oncologists, for oncology surgeons, and also radiologists and pathologists to have a common discussion, to have an MDT discussion, to talk about the protocol. And next, I would introduce the institutions as well as the experts participating in today's webinar. Firstly, the Sun Yat-sen University Cancer Center. It is a very well-known cancer center in China with both teaching, training, medical services, as well as research. So doctors, there are 9 doctors from Sun Yat-sen University Cancer Center. They just compose one team with multiple disciplines. And the director of this group, Professor Zhang Yizhuo, is in charge of this group, has many academic titles in China, and also is a very experienced and a very famous expert in this field of neuroblastoma. And the next group is from the Tianjin Medical University Cancer Institute and Hospital. And our center is also a very important, famous, well-known center in China. We have a history of over 43 years of treating the children malignant diseases. And also there is a team from the Memorial Sloan Kettering Cancer Center, one of the most famous and one of the longest history cancer centers from the US. So here, Professor Modak from MSKCC is also the director of the field and also the pioneer of this field of treating neuroblastoma, is a very well-known expert in this field. And also we have other 2 doctors from US. One is a director of the pediatric department of MSKCC, Professor Laquilia, and also Professor Cassie from the University of North Carolina at Chapel Hill, who is a radiologist. So we're so honored, so glad to meet you all online. And on the webinar today, we will also have real cases from clinical practices, including the adult neuroblastoma patients. And we would like to have this opportunity through the discussion of these cases to have a better knowledge, to have a better understanding of the treatment strategies for this disease. And thank you so much. Okay, so this is my opening remark.
Thank you, Professor Zhao. Thank you for your welcome remark. And Professor Zhao is very famous in China in the field of neuroblastoma and solid tumor. Thank you for your words and thank you for your encouragement. Now, next, we'll ask the US co-chair, Dr. Sheko Mudak, to say a few words. Welcome, Professor Mudak.
Thank you very much for having me and being so hospitable. I'd like to thank Dr. Zhang, Dr. Zhao, and all the participants and organizers of this conference to invite us. And we really look forward to learning together about our mutual experiences on this very rare disease, which is a challenge to treat. It's also a fascinating disease to study and research. And in adults especially, it is the same successes that we've had in children are yet to be realized. But I hope we can continue to improve outcomes in this group of patients and study them together. So I thank you for having me, and I will hand it back to Dr. Zhang.
Thank you, Professor Murdoch. Next, I would like to express our appreciation to the symposium, Cyclone Pharmaceutical, for this generous support to make this webinar possible. Please feel free to ask questions or Q&A window. The speakers or panelists can either reply to you or text in the Q&A window or answer your question loop. We also have Chinese and language simultaneous interpretation for this webinar. Please choose the language equal and then choose Chinese if you prefer to watch the webinar in Chinese language, or English if you prefer to watch the webinar in English. Let me introduce the moderator for the first session, Professor Yan Jie of Tianjin Medical University Cancer Institute and Hospital. Professor Yan, please. Yeah, Professor Yan is the director.
Respected chairs, Professor Zhang, Professor Zhao, and Professor Modek. Good morning and good evening to the US. And today, thank you so much, Professor Zhang, for organizing this case discussion webinar of China-US neuroblastoma cases. Well, firstly, the first case is brought by Professor Lu Suying from Yangtze University Cancer Center, a patient of retroperitoneal neuroblastoma recurrent after comprehensive treatment. So Professor Lu Suying is from the Yangtze University Cancer Center. Is also a very well-known oncologist, very young talent. So next, please welcome Professor Lu.
Okay, thanks very much, Professor Yan. Okay, I will share my slides. Can you see the slides?
Yes.
Okay. Okay. Today I will present. Okay. Today I will present a case with recurrent neuroblastoma. I will talk about it from the following three aspects. The basic information about this patient is the patient is a female, is a girl. She was born in 2004, and the current status of ECOG is 0. The diagnosis of this patient is recurrent neuroblastoma. Firstly, medical records. The patient developed bone pain in late July 2018 and was found to have right inguinal lymph node enlargement in July 2019. Pelvic MR was performed on September 2019, which revealed that there were large soft tissue nodules and masses in the abnormal and pelvic cavity. And there was also bone destruction at L4, L5, S1, and right upper femur. She underwent right iliac fossa mass biopsy, and the pathology indicated that the neuroblastoma poorly differentiate. the MMIC amplification was negative. The PET-CT showed that multiple PTG avid lesions in the left cervical levels 4 to 6, right posterior diaphragmatic angle, posterior area of pancreas, retroperitoneal periaorta, large edge of the right liver lobe, right paralogical area, near bilateral iliac vessels and right parietal area, multiple PDG avid bone lesions throughout the body, suspicious for neuroblastoma. Bilateral iliac bone marrow smear showed that there were no tumor cells, and the neuroblastoma marker MRD was negative. So the diagnosis of this patient was subperitoneal neuroblastoma, poorly differentiated stage M, MMIC negative, high risk. Secondly, the treatment. On October 2019, she started rapid Kojak COS-A, COS-B, COS-C, and COS-B induction chemotherapy. Interim evaluation was performed after 4 treatment courses. The efficacy evaluation showed that the bone marrow smear showed neuroblastoma-like cells, but the bone marrow biopsy showed no neuroblastoma cells. MRD showed approximately 0.04% neuroblastoma cells. And the CT and MR showed the tumor was significantly smaller than before. So the total response of this patient was SD. Then the patient continued to undergo rapid Kojak chemotherapy as COS-A, COS-B, COS-C, and COS-B. On January 2020, she had a bilateral bone marrow puncture and biopsy, which revealed there was no neuroblastoma cells and the MRD was also negative. Then she received operation on January 2020. The postoperative pathology indicated that poorly differentiated neuroblastoma with low MKI, necrosis with extensive lymph node metastasis. Then the patient was given another 2 cycles of TVD regimen. And after that, the efficacy evaluation of PET-CT showed that the response was also CR. Then the patient continued with autologous stem cell transplantation. After that, the PET-MR was also confirmed the efficacy evaluation. The response was also CR. Then the patient underwent radiotherapy with IMRT 21 grade. After that, the patient was given 5 doses of GD2 monoclonal antibody treatments, that is dinotenuoxib. And the patient was also given oral tretinoin. After that, the daughter exam was normal. Then the patient stopped treatment on January 2021 and had regular follow-up. So the first line treatment for this patient was a combination of chemotherapy, surgery, ASCT, radiotherapy, and GD2 monoclonal antibody. Thirdly, recurrence. Unfortunately, the patient had a recurrence when she started treatment for 1 year and 1 month. On March 2022, the PET-CT showed that FDG avid lymph nodes near the inferior vena cava in the right groin, with increase in the FDG uptake compared to the previous PET-CT. Then the patient had the right inguinal lymph node biopsy, which was consistent with neuroblastoma, poorly differentiated type. So the recurrence of neuroblastoma was confirmed. Bone marrow puncture was consistent with bone marrow infiltration by neuroblastoma cells. So she started cycle 1 of topotecan and cyclophosphamide for 1 cycle on 2022. And the total MIBG exam was performed, suggesting red growing involvement. So the patient changed to IT regimen for 1 cycle. And after that, bone marrow puncture revealed no neuroblastoma involvement. MIBG exam showed no pathological uptake. However, total PET-CT showed neuroblastoma involving the right upper inguinal lymph nodes. So, after the patient continuation with IT regimen of another cycle, she underwent right inguinal lymph node dissection. The postoperative pathology showed that metastasis was found in 8 of 10 of the right inguinal lymph nodes. Then the patient received radiotherapy with 2,100 Cgri of the dose. After that, the patient continued to have IT regimen for 3 cycles. And after that, the efficacy evaluation of this patient of PET-MR was CR. After that, she was given 2 cycles of GD2 monoclonal antibody nexitamab treatments. After 2 cycles of the GD2 monoclonal antibody, the response was also CR. Now the patient is ongoing to have the GD2 monoclonal antibody. The patient was also to have an NGS test. However, no cancer-associated genetic mutations was found, and no harmful hereditary stimulation mutation was found. So the treatment for this patient of the response was also the combination of chemotherapy, surgery, radiotherapy, and GD2 monoclonal antibody. So this is the summary case of this patient. Lastly, my questions are, how many cycles of nexitamab should we given? Monotherapy or combination of therapies such as PD-1 inhibitors? And the other question is, are there any better recommendations for follow-up treatment, such as GD2 or GD3 vaccine? That's all. Thank you very much. Hello?
Yes.
Okay.
I think it's directed toward you, Shakil.
Oh, I didn't hear the. Is there a? Shall I address some of the questions? Or is this question for me? Can everyone hear me?
I can hear you.
All right. I'll if I can address some of these questions. I have actually consulted on this patient, so I kind of know the story quite well. And it kind of illustrates some of the challenges faced by young adults with neuroblastoma who tend to have a disease that relapses, as in the case of this patient. After relapse, there is no one right or wrong way to treat this patient. In older adults, we see a higher incidence of ALK mutations. And that's why we were hoping that on the sequencing, we would find an ALK mutation so that we could perhaps treat this patient with an ALK inhibitor. However, we did not find that. And indeed, in adults with neuroblastoma, the incidence of ALK mutations is higher in older adults than in younger adults and adolescents. So the goal after the patient relapse was to get the patient back into remission with surgery, chemotherapy, and after the second remission was achieved, radiation therapy was given to the inguinal area to prevent a recurrence. But because this patient is still at high risk of a second recurrence, we decided to do antibody treatment. And typically we do 5 cycles of antibody, assuming that the patient remains in remission. So that's kind of what we would do. Beyond that, again, there is no unproven treatment, no proven treatment. So we do have a vaccine trial, which we published. We have published 3 papers so far. And the outcome of the kind of bottom line or take-home message from the vaccine study is that so far we know that the vaccine is safe and it is biologically active. That means we see anti-neuroblastoma activity, immunity against neuroblastoma, and we seem to have better outcomes in relapse patients than we did before, but this is not yet proven treatment. So if patients want to participate in the trial, it's open, but we don't have proof that this patient, this therapy is effective. So if the patient lived in New York, for example, it would be an easy call to make. But from patients from China and outside the US, we have to think whether this is worth it. And I don't really know the answer to that. But on the other hand, we don't have anything better in this setting for which there have been data published. So I'll stop here.
Thank you.
Professor Yan, are you online? Professor Yan Jie, Director Yan, can you hear us? So according to the agenda, that means we're going to get to the second speaker, Professor Aglia. Please share your comments. Thank you. Professor Michael.
Yes,
Aglia.
no,
Yeah,
I
thank you.
heard. Yeah, I think in this case, I don't have much to add. I'm a surgeon. I think that they addressed each time the recurrence, the initial tumor and the recurrence with appropriate resection. We see in these patients in the older age group, they tend to metastasize through the lymph node echelons. And I think you see that there with the groin nodes being involved and so forth. I agree with the surgical approaches that were done, and they would go in and resect the tumors during the time of therapy. We think that this is helpful and may make the other therapies more effective. I'm not sure there's as strong a data with regard to the adults as there is with babies and young children that have high-risk disease, but that is our practice. And in fact, I'm doing a case like this on Monday where I'm going to resect tumors in the pelvis and in the parailiac region, the parapsoas region, and so forth. So I agree with the approach of trying to resect macroscopic disease and then using all the adjuvant therapies that we have available to try to control this disease. And many times you can get control. It's just a matter of trying to prevent the next recurrence, which could be, months, a year down the line, something like that.
Thank you very much, Professor Laquaglia. And the next, Professor Casey. Would love to hear your comments. Thank you.
Yeah. So I also agree with what everyone has said so far. And I'm a radiation oncologist, and from a radiation perspective, for neuroblastoma, we approach this very similarly, but a little bit more aggressively how we would with a child, especially upon the relapse, which is to say, I saw the radiation fields, for instance, in this case on the relapse, and you can see they weren't just uncovering the inguinal nodes, they were going all the way up the iliac nodes up to the para-aortic, which is what we would do in such a case because of the nodal extent. So really treating the full chains in that case, especially upon recurrence. And the doses that were used, 21 gray is similar to what we use, and is what we recommend, especially if there's a prior surgery. If there's disease still left behind at the time of radiation, you can consider, although we don't have the best evidence, but you can consider going closer to 36 gray. But in these cases, I agree with the 21 gray and being aggressive upon relapse of treating the, a site like the nodes, or if it's just one bone metastasis, for example, you would treat that. So I agree from the approach from that perspective and getting someone into a full remission.
Thank you very much, Professor Casey. And next, we would love to give the floor to Professor Gao Yuanhong to join the discussion who is with the San Yat-sen University Cancer Center. Professor Yan, because there is an urgent meeting, so we would have Professor Deng, who is from the same department, to represent Professor Gao. Okay, sure, no problems. I'm with the radiation therapy department. I'm Deng Weiping, and I would love to say that this is a relatively older adult, so for the neuroblastoma. So we know that, relatively speaking, when we look at the older patients,
because this is relatively rare for the adult neuroblastoma, so we do not have much experiences. So here we just take a reference for the children patients for the doses of the radiation. So for the lymph nodes involved, we just do a radiation with 21 gray. So here I also have a question to all the panelists, to Professor Dana Kathy, yeah. So my question is that in your center, in your experiences, like an adult neuroblastoma patient, do you think the patient is not sensitive to chemotherapy? Would you just have higher doses, higher than 21 gray, like to 36 gray, or even higher doses for the radiation therapy? Because I read some literature for some of the radiation doses. Well, if the patient or if the tumor is resistant or high risk, they will have higher doses for the radiation therapy. So do you have similar experiences?
Yeah,
Dr. Cassie?
It's a great question, and one which there's no data to guide us, right, in terms of whether or not an adult with neuroblastoma, their biology is different. So the question is, do we use then different doses, which kind of guides how we usually try to treat, right? It's what is the dose needed to get rid of this for good? And so I would have a lower threshold to go to a higher dose in a chemo-resistant tumor in an adult, right? So the side effects in adults are different than in a kid. You don't have to worry about growth. Like when they're treating the para-aortic nodes, they are going from 21 to 36 gray. You don't have to worry about different side effects that you would in a kid. And so, yes, if it was resistant, if there was gross disease, I would consider going higher. I don't have evidence even to extrapolate from kids, we're going above 36th grade for neuroblastoma. So that would be probably the higher limit of what I would go to personally. But somewhere in the 21 to 36th grade range for an adult with neuroblastoma is very reasonable, again, without data to suggest that one dose is going to be better than the other.
I want to make a comment on regarding that. Our approach has always been to surgically debulk the disease first and allow as low a dose of radiation as can be applied. So in this case, surgical resection was completed before the radiation. And I think the radiation fields were completely appropriate.
Right.
The effect of 3600 gray on large bulky disease, I'll ask maybe Dana to comment on that. But typically we try to not radiate large masses and do surgery first.
Yeah, exactly. So that's why I think the approach here was the exact right approach. Was we would much rather, we're much more successful with neuroblastoma for treating microscopic disease that we can't see. Anytime we're treating disease we can see, we don't do as good a job, but we know that for a fact. So that we do have evidence for that. And 36th grade does not make up for that completely even itself. So we don't want to be radiating bulky. It's more just a question of if there's a little area you need to boost with 36th grade that is left over, right? You feel more comfortable doing that in an adult than sometimes in a kid where you're more worried about the late effects. But yes, we much more successful radiation wise with microscopic residual disease, whether that's a child or adult.
好的，谢谢 Cassie 和 Moderator 教授。
Okay, thank you, Professor Moderator and Professor Cassie. Okay, next, please welcome Professor Li Jie and Professor from Tianjin Medical University Cancer Institute. So we could see this case. This is the first diagnosis at the age of 15, the adolescent onset of this disease. But for the adult period, there is a recurrence. So here for this high-risk neuroblastoma, for the first of the primary diagnosis, this is very standardized. Chemotherapy and then stem cell transplantation and then radiation and then immunotherapy. So for this patient, well, for the previous treatment is very standardized. So after the treatment period of time, about 1 year, this patient has a recurrence. So here for the recurrent patient, well, there is no standardized consensus or guideline to guide us. So here, we just have an individualized treatment according to the experiences. So we have the second line protocol with topotecan and cyclophosphamide, and also the TIT chemotherapy. Well, it has a relatively good efficacy, and after CR, we just have this naxitamab. So here, this is a continuous CR for the patient. So here with the immunotherapy, what about the cycles for immunotherapy? Well, there's no solid data or evidence from clinical practices we can follow. But we can only just obey those instructions for the use of obstructions like the 7 cycles of naxitamab. So also we can see from the data of the clinical trials, they do not strictly follow the instructions of the medication. If the patient is well tolerated, the cycles can be increased. So if the patient has adverse events is not well tolerated, the number of cycles may be decreased. So here we just have this exploration for how many cycles should we apply the monoclonal antibody, and also for the practical conditions of the patient will guide our strategy. Or we have this combined therapy together with a PD-1 inhibitor, or we have a tumor in vaccines. I think currently they're still under the phase of clinical trials. So to the individualized treatment, we do not have much experiences. We're still under exploration. Only we just depend on our explorations in clinical practices. So these are my comments to the 2 questions. Okay, thank you. for your comments. And here I have a question for Professor Modek. Well, if we use the PD-1 antibody, will the patient benefit? So this question is for Professor Modek. What about benefit for
I don't think there is any role. I don't think there is a role for PD-1 inhibition because neuroblastoma is notoriously not infiltrated with T cells, both in adults and in pediatric tumors. Neuroblastoma doesn't express HLA class 1 molecules, and it's a particularly bad target for PD-1 inhibition. We have tested a large group of neuroblastoma tumors to look at PD-1 and associated molecules, and invariably we find that these are absent. Clinical trials that have included neuroblastoma for drugs such as nivolumab have also not shown any benefit. And so we have to find a different way of harnessing T cells. Our group has looked at a bispecific antibody, and other groups have looked at CAR T cells. And again, these have also not shown benefit in early clinical phase trials, but perhaps further enhancement of these agents might be useful. As regarding the number of cycles, what naxitamab costs in China, that's certainly something that has to be kept in mind. And in the US, it is extremely expensive. But because insurance covers it, we have more freedom to use it. But I'm not sure whether what the cost and expenses for this drug are in China. I assume they're still quite high.
Okay, thank you so much for Professor Modek for the very detailed information. And for the neuroblastoma, this is the cold tumor for immunotherapy. So the benefit for PD-1 antibody is very limited. Thank you for your explanation. And next, please welcome Professor Li Zhanglin from Tianjin Medical University Cancer Institute and Hospital to make a comments. Okay, good morning and good evening. And I just listened to the case from Professor Liu. So they take reference for the children strategy for treating neuroblastoma, and the previous treatment it is very standardized. And after 1 year, there is recurrence. It's a local recurrence in the lymph nodes. And after chemotherapy, well, I think the results, the efficacy, and also the following surgery and radiotherapy, the patient reaches CR. So this is a very local lymph node recurrence. So the surgery together with the local radiotherapy, I think this is a very good strategy. And also there is several cycles of chemotherapy. So for the maintenance therapy, I think like for the long-term adverse events for the chemotherapy, and also for the question just mentioned, for the single application of GD2 immunotherapy would have a better safety, for the long term of the patient. And also about the accessibility of this medication, well, the cost of this medication is very high. Well, in China now we have this maintenance therapy. We have 5 cycles of the GD2 antibody. Well, addition therapy would also add the economic burden to the patient. And also for the GD2 and GD3 vaccines, because in China, it is still under clinical trials, not accessible in clinical practices, still under exploration. But also for the vaccine, I think for the mechanism of the vaccine, well, the vaccine to stimulate the endogenous antibody production for the body. So, but for the GD2 antibody, it is from exogenous. So although from different ways, from different sources, I think the final results, they may have similar efficacy. So, but still under exploration. So I think, to my own viewpoint, I think immunotherapy as a maintenance therapy would be better. Okay, thank you, Professor Li. Okay, next, please welcome Professor Zhang Yu from Sun Yat-sen University Cancer Center to make a comments to the 2 questions. Okay, good morning and good evening. I am a pathologist, So I'm a pathologist in the pediatric malignant diseases, but most of the diseases we meet, they are pediatric malignant diseases, but rarely we meet adult disease. Well, the oldest patient is a 62 years old neuroblastoma patient. So commonly, generally speaking, well, we have a young age patients. So for this patient, for this case, the diagnosis is no problem. So according to the bone marrow smear, according to the biopsy, and also other lab results, it is a low differentiated neuroblastoma. So here we have information to the clinical doctors at the primary diagnosis in 2019. Well, the Ki-67 is 20%. So this is a low KMI, but at the recurrence, the Ki-67 just comes higher to 50%. So here, although there is no information for MKI, but I think it just already meets the criteria for high MKI. So here for after chemotherapy or radiotherapy, well, most of the cases, they will have the neuroblastoma, they have the necrosis as well as the higher differentiation. But here, after the treatment, it seems that the case just has a worse differentiation for the new neuroblastoma cells. Okay, so here I still have another question.
Professor, I have another question. The patient is an adult patient with 44 years. She had a recurrence of multiple metastases with bone metastasis. Unfortunately, she had ALK RER-CoQ mutation. ALK mutation, RER-CoQ. Okay. RER-CoQ. Okay. Okay. Can you share your experience with the use of ALK inhibitors? How long should we give in? Thank you.
I actually have a slide to share, if that's okay. Is that okay?
谢谢某大哥教授，
Okay.
请。
Let me see if I can. So if you can give me 5 minutes, I'd like to just these two slides. Can you see my screen yet?
看到，
Okay.
请您全屏一下。
Okay.
Yes, we can see it, but it's not in full screen. If you can
Yes.
get to the, thank you.
All right. We have just published. Can you see my screen now?
Yes, it's good. Thank you.
We have recently submitted for publication role of ALK inhibitors in 15 adults ranging from 18 to 70 years of age. And these two pictures are from that paper. So the conclusion of that study is that lorlatinib gives you the best responses by far. Of the 15 patients we talk about 6 or 7 of them initially received ALK inhibitors other than lorlatinib, whereas all 13 out of the 15 actually received lorlatinib either as the first line or second line, and all the responses we saw go to lorlatinib. And this is an interesting patient. She was 27 years of age at diagnosis. She presented with a localized disease with a pelvic tumor. And after about 1 year of lorlatinib, the pelvic tumor had reduced in size. But what was more interesting was that the pelvic tumor had gone from being positive on PET to negative on PET. So we are not only seeing responses to lorlatinib, but we are also seeing metabolic ablation in a way. Now, while I was putting this paper together, as you can imagine, this is a rare disease, so it took us a long time, maybe over 5 years or so. Our responses to lorlatinib were superb, and they were also durable. But over the last 3 months, I've had 3 patients who have relapsed while receiving that. So that kind of, makes us pause a little bit, because for a couple of years, I was thinking that lorlatinib is going to actually cure these adults. But unfortunately, it has not. And we still need to think about how to treat these patients. Many of my adult patients respond really well to lorlatinib after not having responded to chemotherapy. But now we are seeing relapses while the patient is receiving lorlatinib. So single agent lorlatinib, I think, even though there is a lot of, and indeed it has very good responses and is associated with much better quality of life than chemotherapy, but I don't think single agent lorlatinib is going to cure our patients. In adult patients with non-small cell lung cancer who have ALK mutations, my adult colleagues start treating them with drugs like ceritinib and alectinib, and only later on, and these patients keep on relapsing. On ceritinib, they last for 1 year, then they go on to the second inhibitor, and then they go on to lorlatinib. And adults kind of seem to be following that pattern. That is, they respond very well, but then they break through. The question is, why do they break through, right? So one reason could be that ALK inhibition gets rid of all ALK mutated cells. But when we look at the recurrence using circulating DNA, we see the ALK mutation is the same as before and at higher numbers. So the mechanism of resistance to ALK inhibitors is not the emergence of an ALK wild type clone. It has to do with the same clone as before, which has probably gotten resistant to that particular ALK inhibitor. So I wanted to share that with you.
好，谢谢Modak 教授。我还
Thank you
想
very much, Professor Modak. I have a follow-up question, because if ALK inhibitors have already inhibited their activity, then already the tumors are reduced for the surgery. If that is the timing for the surgery, would the patients benefit from surgery?
Great question. So that's precisely what we did for this patient, which I showed you. I think Dr. Lakwalia may have operated upon her. So for localized disease in adults who have inoperable tumors, this patient's tumor was deep inside the pelvis, so could not be removed. But for those patients, this strategy may work. That is, we shrink the tumor with lorlatinib as much as we can, and then we go in and remove it. And I very much hope that this patient is cured. But those patients with metastatic disease, which is most of the patients, if we keep them on single agent lorlatinib, I fear that they will break through. And we already have 3 patients who have broken through. And now for future patients, even those whom I'm currently treating with lorlatinib, I will probably be recommending adding antibody treatment to the lorlatinib, because adults don't tolerate antibody very well, but I think we might have to learn how to use it in them.
Great, Modak 教授。
Great, thank you very much, Professor Modak. And now, Professor Yang, if I may, have
Dr. Professor Modak, what do you think about the autologous transplantation in the treatment of neuroblastoma in elderly patients? Thank you. 就是年龄大的患者啊。
I think this will, if we start talking about this, it will take us another hour. But we have not been doing any transplants since 2003, even in children. And I think we can perhaps talk about it as we go along as to what is the rationale for not doing that. We are one of the only two centers in the big centers in the world who are not doing transplants. And the reason for that is in adults, I would particularly not do transplants because adults cannot tolerate even the chemotherapy that's used in children very well. And to put them through transplant is kind of cruel. We've, in the old days, 25 years ago, when we did transplants, we had 2 adults who actually died during transplant. So I'm completely against this approach in adults. I think we've got to be smarter and maybe learn how to use ALK inhibitors and immunotherapy better.
好的，好的，非常谢谢莫
Great,
大。
thank you very much, Professor Modak. And in the interest of time,
进行到下个疗程，一会儿其实还有
we can get to the second part because later we will have more time to ask our 3 professors from the US. And next we have the case sharing by Professor Wang with San Yat-sen University Cancer Center. We have the 26-year-old male patient of the retroperitoneal MB case. So I would love to share my screen. Thank you. So everyone can see that? Yes, we can see that. Yes, and the presentation mode. Thank you. Great.
I will share one case about refractory stage M high-risk adult neuroblastoma. Now, basic information and medical history. This is a 26-year-old male. Complaint is back pain for more than 3 months, anemia for 1 month. The history is the patient presented with low back pain and was found to have moderate anemia in May 2022. The hemoglobin is 93 gram per meter, and NSE was 103 nanogram per millimeter. During the examination at the local hospital, the MRI reveals that multiple abnormal signal foci in the T9 to S1 vertebrae, sacrum, and bilateral iliac bones, bilateral femoral head, and inner neck of the femur, indicating that possible metastatic lesions. And PET-CT scan shows that soft tissue nodules with maximum size of 13 and multiple 14 millimeter in the left retroperitoneal area, and nodules with maximum size of 9 multiplied 10 millimeter in the left adrenal gland, as well as multiple bone metastases in both cerebral and peripheral areas. The bone marrow biopsy confirmed the diagnosis of metastatic neuroblastoma, with flow cytometry showing 3.7% abnormal cells that were CD45 negative and CD56 positive, and CD117 positive, indicating that extramedullary cell source. On August 29, 2022, the pathological examination of the retroperitoneal mass biopsy reveals a small round cell tumor. The clinical diagnosis was stage M neuroblastoma, with originating from the left retroperitoneal with lymph node and multiple bone and bone marrow metastases. It was a high-risk group patient. This patient received 2 cycles of CTX and VCR and DDP and VP and 16 chemotherapy at the local hospital. And after the chemotherapy, the back pain was removed, and the patient was then come to our hospital. This picture was the imaging result as a diagnosis. We can see that the softer tissue at the left adrenal gland and the retroperitoneal area, and high hypermetabolic lesions on multiple bones. The MR scan is not at the diagnosis. It's after 2 cycles of chemotherapy performed at our hospital. The MR shows that enhanced foci were observed in the right parietal lobe and with multiple lesions in the skull. Not the metastases were not excluded. The other test in our hospital was that the pathological consultation was suggesting that it was a neuroblastoma, and MRI showed the foci enhanced focal enhanced in the right parietal lobe. And multiple lesions found in the skull, indicating possible cranial metastasis. And chest, abdomen, and pelvis CT scan shows that left adrenal nodule about 11, multiple 17 millimeter, considering metastatic tumors. And the bone marrow aspiration shows that after 2 cycles of chemotherapy, there's no tumors were found in the left posterior iliac bone marrow, but there are still some tumors were seen in the right posterior iliac bone marrow, iliac bone marrow. And the mechanism was not found application. NSE was 38.7 nanogram per milliliter, and urinary VMA was 103.8 nanogram per 24 hours. The WS test was also performed for the peripheral blood and the primary tumor sample. There are many somatic mutations were found, but for example, EED, FAT4, NOTCH1, MUC16, but no ALK gene mutation or amplification was found. The MECN gene amplification was negative, and no 11q deletion was detected. And testing was performed on 65 cancer susceptibility gene mentioned in the clinical guidelines, and no clearly harmful germline mutation was identified. The treatment after the patient come to our center, we gave him CAV alternate VIP regimen. The dose was CAV includes CTX 1 gram per meter per dose, day 1 to day 2. And THP is 50 milligram per square per dose. On day 1, VCR was 1.5 per square meter per dose on day 1, and VIP include VP 16 100 milligram per meter square per dose from day 1 to day 4. DDP 25 milligram per square meter per dose from day 1 to day 4. The IFO was 1 and 1.5 gram per square meter per dose from day 1 to day 4. After 2 cycles of the chemotherapy, the CT scan shows that the primary tumor was SD. After and we give the ECT scan shows still many bones was radio density and maybe the tumor of the bone was residual. No tumor on the cranial MRI, and the bone marrow aspiration after 4 cycles shows that 1% of the tumor cell in the right posterior iliac bone marrow, whilst there's no tumor residual on the left posterior iliac bone marrow, and the flow cytometry also is negative. This after 4 chemotherapy, there's still a tumor in the bone marrow, so not achieved CR. So this patient was defined as refractory stage M high risk neuroblastoma. So we changed the chemotherapy regimen. We switched to the apatinib combined with irinotecan and IT regimen. The bone marrow was achieved CR after 2 cycles, and CT scan after 3 cycles of the apatinib and IT regimen showed the primary tumor shrinked, and the dose, the regimen of the apatinib combined with IT regimen was that apatinib is a small molecular tyrokinase inhibitor that can highly selectively bind to the VEGF2 and taken orally once daily on a continuous basis until disease progression, patient withdrawal, and acceptable toxic effect. The dose was that the weight less than 20 kilogram, 0.125 gram orally once daily, and the weight between 20 kilogram to 40 gram is 0.25 gram orally once daily, and if the weight is between 40 kilogram to 50 kilogram, and is 0.5 gram orally once daily. The irinotecan was is 50 milligram per square meter per dose from day 1 to 5, and temozolomide is 150 milligram per square meter per dose from day 1 to 5. And after 3 cycles of chemotherapy, this patient received the operation and a resection of the retroperitoneal mass and left adrenal masses. And post the operative pathology, it shows that neuroblastoma, and that it is a different subtype, and is post-treatment changes. After operative CT scan shows that no residual tumor was seen at the primary tumor site area. And the patient's current condition. This patient has received 5 cycles of apatinib and combined with IT regimen chemotherapy. Now the patient was achieved CR of the bone marrow and primary tumor, but we have not evaluated the bone lesions. we plan to give the PET-CT and MIBG examination after 6 courses of Apatini and IT regimen, and we will plan to give the radiotherapy to the primary tumor site area. Now, discussion is that 3 questions. One is a patient is an adult with refractory stage M high-risk neuroblastoma. If immunotherapy is chosen to subsequent treatment, which GD2 monoclonal antibody do you recommended, and whether can you which one do you choose? Immunotherapy alone or chemotherapy combined with immunotherapy? And the 2 question is that if the patient doesn't take the GD2 immunotherapy, stem cell transplantation or oral chemotherapy, which one do you recommended for maintenance treatment? And the 3rd question is that as we know, the frequency of the ALK mutation is high in the adult neuroblastoma. If the patient has ALK mutation or amplification, would you choose an ALK inhibitor as a first-line treatment? If so, which generation of ALK inhibitor would you prefer? Thank you very much.
谢谢。下面咱们按顺序有请Modak教授。
Okay, thanks. Firstly, please still welcome Professor Modak to give the comments to these questions.
So firstly, I'm really glad your patient had a response to the point that you could operate. I'm still unclear whether this was a true response because there was only 1% bone marrow disease. I think that's correct. And you have not done a PET or MIBG, right? Is that correct?
Yes.
But I'm still hopeful that this will turn out to be a true response. The apatinib is an anti-VEGFR agent, and we have treated. We published on bevacizumab plus irinotecan and temozolomide in patients with relapsed disease. We did not have most of our patients, all the responses were stable disease with some responses, but not in all the body compartments. So we never actually got anyone into complete remission in about 25 or so patients. The European group has treated patients with bevacizumab and irinotecan, and their response rate is slightly better than ours. I think there is a role for it, but I don't see VEGF suppression as being a major player in neuroblastoma. So that is one comment. Second comment is about antibody treatment, but I think first we've got to see whether the patient is in remission or not. If the patient is not in remission, that is, the bony lesions are still lighting up on PET scan, then you could consider doing chemoimmunotherapy or naxitamab plus GM-CSF. If you decide to do chemoimmunotherapy, we have combined dinutuximab with cyclophosphamide and topotecan. So I would change the chemotherapy if you don't have a complete remission at this point. Another option would be to do naxitamab plus GM-CSF only without chemotherapy. And if you take all patients, adults and children, the response rates for chemo-refractory bone marrow disease and bone marrow disease is very high, as high as 75% or 80%. So having said that, in adults, I would expect that to be less, and also to treat patients with adults with these two drugs is not easy because they don't tolerate the antibodies that well. Your patient is 26 years old, so I think he or she will actually tolerate it okay. We have treated younger patients with quite a lot of success. If the patient was 40 or 50 years old, it would be harder. third question is about, say, if we don't do anti-GD2 antibody, then what do we do? Again, it depends on whether the patient is in remission or not. If the patient is in remission, then you might want to do maintenance apatinib plus irinotecan temozolomide, because that would be a wonderful response. Have I covered all the three questions, I think? ALK inhibitor, we have not seen any responses to any other drug except lorlatinib. Of the patients, adult patients we've treated, we did not see any response to crizotinib, ceritinib, alectinib, or brigatinib. But there were only about 7 or 8 patients. So lorlatinib cost might have to be kept in mind, but I don't know how that what's the scene in terms of getting the drug. But we have not seen anything like the responses we see with lorlatinib with the other drugs.
Okay, thank you, Professor Modak. And next, please welcome Professor Professor Laquelia.
Thank you. As a surgeon, I don't really have much to add. I think this is one of those neuroblastomas that has not a lot of soft tissue disease and extensive bony metastasis. So I think the systemic therapy is paramount. I think that the surgery that was done well. They removed the primary tumors. They were able to remove the primary tumors, and that will have some efficacy. We, as surgeons, we like it more when there's a big soft tissue mass and very little in the bone marrow, and then we can, I think, contribute more to the case.
I would also, as a segue to Dr. Casey, I think I would do radiation sooner rather than later on this patient.
Yes, I agree. Getting in right now when they've had the response and when the disease is out and there's not bulky or gross disease is going to be important for the ultimate success of the primary site. Obviously also pending that PET or that MIBG that's still waiting to happen, but then I would go for the radiation therapy.
And also, I think if there are a few residual sites and bony sites, any comments on that?
Yeah, so if there's a few residual sites, we always would include them when we're treating the primary site. They don't have to be contiguous. You can do separate sites, but you would treat to the same dose or while they're receiving radiation already, because that's your time to consolidate them. So this patient did have widespread disease, but at this point, if there's anything residual in MIBG and PET, I would also target those sites.
Thank you very much, Professor Casey. And I would love to ask Professor Laguenia, because that means for the treatment of the neuroblastoma, after how many cycles of chemo you will consider surgery, or actually 4 cycles or 5 cycles, or until 7 or 8 cycles, so then you see the cases getting to the stage of surgery. Thank you for what you have seen.
Yeah, so we actually published many years ago, it's in the Journal of Surgical Research, the decay of the volume, the volume of the primary tumor with the chemotherapy, with the cycles. And you really get the most effect in terms of the volume of the tumor, the most reduction in the volume in the first 2 cycles, and then a little bit more on the 3rd cycle. After that, it goes out like an exponential. Also, we looked at some of the vascularity, and the vascularity, these tumors can be quite bloody when they're diagnosed. The vascularity goes down as well. So we at Sloan have usually used done surgery on the primary tumor after 3 cycles of chemotherapy. I think somewhere between 3 and 5. I think if you wait and do it after many cycles, this might encourage resistance. I also have a feeling that you have more fibrosis or scarring around the tumor. And so I think somewhere between 3 and 5 cycles. I think the Children's Oncology Group is now going to 4 cycles on the new studies. I think in that range of things, but not prolonging it much after that.
Thank you very much, Professor Guanglia. And next, we would love to move on with our discussion. We also have Professor Cao Yanna with the Tianjin Medical University Cancer Institute and Hospital. Thank you very much. And just now, Professor Wang has given us the case, which is a 26-year-old adult, relatively young adult with the neuroblastoma. So at the initial diagnosis, so that patient is already at the stage M. And the earliest treatment probably was not done in the Tianjin University Cancer Institute. So it was not really following through the standardized recommended chemotherapies for the children. And in the pediatric neuroblastoma, this is also relatively rare because it's not a primary lesion, but there is more metastasis into the cranial, to the CNS, etc. Because I haven't really remembered that clearly for the CNS. So maybe it's not the solid lesions in the parenchyma of the brain, but it's more about the cranial or skull lesions. And then it is also growing and the compression to the parenchyma. So that looks like some invasion to the CNS. So probably that requires some more subsequent tests or examinations to confirm that. And according to the therapies given, it's based on the refractory recurrent therapies to my view. And we look at the primary lesions and also the metastasis of the whole body. It seems that for the initial chemotherapy, this patient is not satisfactory. And in the pediatric chemotherapies, usually we see much better one than this. So it's not like a lot of the reduction in the size of the volume, but after the resection, it seems that the pathology showed it was differentiated. However, the primary lesion is not the major factor of prognosis, but the control of the primary lesion, of course, will have some impact on the prognosis. Or the resection is done, and after the treatment, it has reached the CR. But of course, whether the patient will maintain the CR, that is something for us to have subsequent treatment. So my personal view is that since already we are treating this patient with the refractory recurrence case, already CR at the imaging level, and also already the surgical resection is made at the primary lesion, probably subsequently it's more about the systemic therapy, and that might be better. Of course, then we would need to follow the recommended guideline to get to the maintenance therapy. That's my view to fit for this patient, because already we know this is not a sensitive patient to chemotherapy. And also we look at the adults HSCT with the hematopoietic stem cell transplant, would that be acceptable? Whether this patient is fit enough, that depends. And also, I believe that immunotherapy after that would also be appropriate. If this person cannot accept that, then we can carry on with the targeted therapies plus the small dose of the chemotherapy for maintenance. So that's my personal view. Of course, except for the apatinib, the targeted therapies have something else. So for example, on our patients, they have allotinib, and also that's multiple targets. It's also working with the IT regimen as a combination, and the efficacy we're looking at is satisfactory. Basically, they're maintained at SD or actually stability, and also the chemotherapy can be extended with the longer cycles, so that can also help us reach stability. For the ALK inhibitors, we check or search for those with the ALK mutations. If there are mutations, there are applications, there is some different approach because we don't have a lot of them. And there are those with the mutations, but they're not really very good. But we used the crizotinib, whether it's eritinib or alectinib. But when we really look at this kind of toxicity, it seems that the hepatotoxicity is higher. Lalatinib is not accessible right now in China, so we used more crizotinib, and it's not satisfactory in terms of efficacy. So in terms of ALK inhibitors for now, personally, I think I don't want to recommend that. So that's my personal comment. Thank you very much, Director Zhao. And next, we would love to ask Professor Dong from the Science University Cancer Center from the Radiology Department to share. Sure, no problem. I would love to ask a question to Professor Casey or Professor Maldak, because for this patient, if the patient has the primary lesion in the abdomen, and then for this patient, there is some metastasis into different bone marrows, the cranial part, then after the chemotherapy, then we basically get to the CR, then we would consider the radiation at the primary lesion. But then when you look at the other bone marrow lesions, so that's also CR. And then for the metastasis lesions, so do we need to go through the radiation? Because Professor Casey earlier mentioned that she probably will think about the radiation and the residual minimal or this kind of microscopic lesions. How do you tell that? So PET CT, or you would need to have the multiple bone marrow taps in order to know?
So what we're really targeting is more the bone lesions, not necessarily bone marrow. And so it's more of the MIBG or the PET that's directing where we're guiding radiation therapy, not bone marrow positivity. So we're not targeting bone marrow in those cases. It's always a question, it's about how many sites to treat is too many, right? And I think that's where that would be guiding. If there are a lot of sites that were still there and bone marrow positivity, I'll defer to Dr. Moda, but I think at that point, we're thinking more obviously systemic routes as opposed to targeting tons of sites with radiation therapy. Even in an adult, it's just not the right treatment for them. But if there are just a few sites, that is something that we would do with the residual. I also was chatting back to this question in the stream. I don't know if it's easier for me to keep typing it or respond out loud about proton therapy, but I'm happy to keep typing it if that's the best route for that.
I think it'll be good to talk about it because
Okay.
it's in the last.
So the question in the chat was about considering the balance of benefits and side effects in neuroblastoma. What are the thoughts about proton radiation for treatment of the primary tumor? So we have more and more data supporting proton therapy, especially intensity modulated proton therapy, which is a newer form of proton therapy for kids with neuroblastoma, and how you can actually spare the anterior structures in the abdomen, like the bowel, from dose, pancreas as well, which is a risk of diabetes from radiation. Because the doses we use for neuroblastoma are relatively low, whether or not that translates into a clinically meaningful difference, we don't know yet. But we know for second cancers after radiation, for instance, that the risk of second cancers is linear with dose. So if you can spare more dose to anterior structures with bowel, with proton therapy, obviously beneficial if it's available to you. Now, because we don't have a clinically meaningful difference, and because the dose is relatively low for an adult, if the proton therapy was not available at the center, I would not make an adult travel for radiation therapy, but for proton specifically. But for children, it's something we are always considering now. And if it's available, I personally would use protons dosimetrically. It makes sense to share the anterior abdominal structures.
Thank you very much, Professor Casey. And next, we would love to invite Professor Li Jie with the Tianjin Medical University Cancer Institute and Hospital. So we have already heard a lot of discussions, so I'll be brief. And for this patient, after the previous treatment already, the efficacy is quite good. Whether we use the first line treatment, this patient was refractory, or actually we switched to apatinib and the IT regimen as a combination therapy. For now, I think this is a good efficacy for the patient. And then we haven't got more analysis, but in the future, we can have the MIBG and the FDG analysis to see what are the residual diseases, of course, if they're limited number, the radiation therapy will help us with a lot of benefits. And then for the subsequent immunotherapy is something to consider. And for those, we have CH1318 bit, and also we have the naxitamab already in China. I don't think this is good for this patient because when they're limited to the bones and bone marrow, naxitamab is good with a really great efficacy. But which one to choose? This is something about the economic consideration and the patient's consideration, because when we look at the two antibody patients, the prices are very different in China. So it depends on the affordability of the patient, and then they can choose. I think it would work. And going forward, if this patient would be able to afford the immunotherapy, I know that the Penn University Cancer Center published a data paper about the minotropic chemotherapy, which is oral administration. And I don't think it's something not to consider, because when we think about the oral administration, that's also great in terms of efficacy too. So this is something to consider. If there are ALK mutations where they can also fit for the ALK inhibitors with the indication of the mutation, then that's another choice. And then we can maintain the treatment. That's all from me. Thank you, Professor. And next we have another panelist with Penn University Cancer Center, Professor Li Xiangdong. Thank you very much, Professor. And I would love to say I'm a surgeon, and this is already a patient with a good efficacy for neuroblastoma in adults. The primary lesion is a retroperitoneal, and it's not even large lesion, less than 2 centimeters compared with the other many cases with a neuroblastoma. This is a little different because for the other cases, the primary lesion is already large. With the distal metastasis after 4 to 6 cycles, so they might have a reduction and we can get to the surgery. And then for this patient, the surgery was also done in our department, and this patient used the Da Vinci a minimal invasive robot surgery. It was also a very success. And I would love to ask Professor La Quaglia, because if the primary lesion was not large, if we go for the resection of the primary lesion before we go for the subsequent therapy, would that also be something to consider as a good efficacy potentially?
So there was actually an analysis that was done in the COG because it had been thought in a preliminary way that doing that would be helpful. But in a larger analysis from the COG that has been done, initial resection of the primary tumor, even a small primary tumor, does not seem to affect subsequent progression-free survival. I think that the problem, of course, of doing a big operation before the patient, whether it's an adult or a child, has had chemotherapy, is that you may delay the chemotherapy. And so our feeling has been to if it's high-risk disease, to go ahead and start systemic therapy after getting the diagnosis. I congratulate you for using the robot to do this. This is sometimes can be very good for these small lesions and so forth. Of course, most of them are encasing all the major vessels, and we can't do those robotically. So unfortunately, we have to make a very big incision to see adequately and so forth. But I would congratulate you for being able to use the robot for this.
Mike, if you had the robot, would you prefer that to
we have
the patient up, because most of the time you see more disease than the scans show, don't you?
You do see more disease. You have to be careful because so the answer to Dr. Modak's question is if it's a small tumor, we have done some of those laparoscopically, but you do have to be careful to not only address the primary tumor, but the regional lymph nodes. If you're going to do surgery, you might as well take out all the disease that's there. And sometimes this disease is not evident until you're actually dissecting the tumor. Having said that, there are small tumors that we've been able to manage with a laparoscopic approach. They're extremely rare, of course. The advantage of the laparoscopy or the robotic procedure, which is really a laparoscopy, is that this patient had so much disease elsewhere and had very small primary tumor. So it was a little bit less for the patient and ability to get back into the systemic therapy a little bit faster. So I don't have an objection to that. We do see, however, patients who have laparoscopy or robotic approach, and they come to us with residual disease. They didn't take it all out. So you have to be careful. But if you do that, and it depends on how much disease there is and how familiar your ability to dissect out the aorta and the vena cava. But if you do that, and you can do that for small lesions, then I think it's okay and has some advantages in terms of the recovery of the patient and the ability to go on with further therapy. I would not do it in most cases because I think what we've seen is they've left disease. They've injured the kidney, they've left disease, they've done something that we wouldn't necessarily happen if we did it open.
好的，谢谢老
Okay,
贵的。
thank you, Professor Lagulia, for your answer. And I have a question. So here, well, for this patient has the abdominal primary tumor and also for the lymph node metastasis of the neck and also the median sternum. So here how do you do the surgery to do it in different times or together?
So we do it together. It's not uncommon for us to have a large abdominal tumor, but we often see on the left side, especially for some reason, it has to do with the way the lymph drainage is. We see these left level 4 and level 5 lymph nodes or the lower neck lymph nodes. And it's rather straightforward to do what we call a modified neck dissection. We make an incision that goes along the lines, not up and down like they do, but along the lines of the skin. And we can go ahead and retract the sternomastoid muscle, retract the jugular vein, and simply get the lymph nodes out. And it's actually pretty straightforward. It takes about an hour and a half or so, depending on the extent of the disease. And then we close that and then turn the patient up. And usually we do a thoraco-abdominal approach to the upper abdominal disease. With regard to the mediastinal disease, occasionally, this can occasionally be resected with the thoracoscopy if it's limited, or sometimes we do a small thoracotomy. Sometimes if we have to do both the chest and the abdomen, we can do it if we do it through a thoraco-abdominal and if the disease is low enough. If it's high up around the arch, then sometimes we come back and do a second operation. We probably give a round of chemotherapy. I think the principle is to try to get as much of the gross disease out. These operations in the neck are not very morbid. They don't cause a lot of problems. The scar is pretty invisible. I think getting the gross disease out again prior to the further radiation and the chemotherapy is helpful. So I'll do the neck and the abdomen, and sometimes I can, because I use a thoraco-abdominal incision, an incision that goes along the flank area and opens the chest, I can sometimes do the nodes in the chest at the same time. And then we do the abdomen. So many times we can get it all in one. Sometimes we have to do a second operation.
好的，谢谢老贵的教授啊。
我也有一个问
Okay,
题。
thank you for your answering. And here I also have a question here for Professor Lagulia. I am a oncologist. Here I also have so many questions for the surgeons. So here from the MSKCC for the neuroblastoma for the children for the surgery, do we do the resection as much as possible to resect them all? Or for some of the lesions, we cannot resect at one time. We just leave it to the chemo or radiotherapy. So how do you have the principle in your clinical practices in MSKCC?
So I think the principle, of course, is we're there to help the baby and the child. So we don't want to do anything that's going to cause major problems, bleeding, and so forth. Having said that, we are very aggressive about removing the primary tumor. And in about 95% of the cases that present with encasement of the blood vessels, I'm not talking about the, just an adrenal mass, but encasement of the celiac axis or the superior mesenteric artery or the renal arteries or the aorta or the vena cava, we are able to perform what we call a gross total resection. The surgeons call it an R1 resection. And this is, we peel out all the tumor we can see or feel. We feel very, very strongly that you have to see the normal structures, that you can't go and try to feel it because these are soft tissues. They're in an area of a lot of other soft tissue. And so palpation, feeling the tumor, we find is not as good as going and actually dissecting out all the structures. And it's really becomes a vascular dissection. You dissect out the blood vessels, and then once you have them all dissected out, the tumor comes out. So we try to do as complete a resection as possible. Of course, we don't want to hurt the child if there's too much bleeding and it's a problem, then we try to reduce it as much as possible and put clips. But this happens only in about 5% in our experience with encased blood vessels. I think the real help here is opening the chest and the abdomen, which was a procedure described by the vascular surgeons to fix the aneurysms of the aorta and the big blood vessels. And so we use this same incision because it's good exposure to get to those blood vessels. And we take a lot of time for these. These are long days, depending on how extensive it is. On rare occasions, we have taken out tumors, for instance, from the left side, but there's residual around the head of the pancreas or way over to the right. And then we'll let them get through that operation and then come back maybe after a cycle of chemotherapy and come back and do the other side. But that's very rare. Most of the time we can do it as long as we use the thoracoabdominal approach for the upper abdominal. For the lower abdominal, we use just a laparotomy approach.
Okay, thank you so much for your detailed explanation, Professor Laguilia. So this is the 2 adult neuroblastoma cases. Both of them, they are refractory and recurrent cases. And from these 2 cases, we could see for the adult neuroblastoma, though the general approaches of therapy is similar to the children neuroblastoma cases, but for the adult patients, there are more ALK mutations or amplifications. It is also reported in the literature, and also for the pre-op chemotherapy and the post-op radiation. Well, they are the mainstream treatment strategy for the patients. And for the first case, he also received a stem cell transplantation, but for transplantation, it is not often applied in MSKCC, but in many centers of the other regions and countries, well, especially also in the guidelines, there is still this step of the transplantation. So here because of the induction of immunotherapy. Well, the key point of immunotherapy would be more obvious, and through continuous clinical trials, no matter it is in children or in adult, we are trying to give them the optimal therapeutic strategies with a low toxicity and a higher efficacy. And to this point, it's also the point that we want to have further communication as well as collaboration. So next, I'll give the floor back to Professor Zhang Yizhuo.
Let me introduce Dr. Li Zhongyuan from Tianjin Medical University Cancer Center and Institute to present experience in the diagnosis and treatment of adult neuroblastoma. So, Dr. Li, please.
谢谢张主任的介绍。
Okay, thank you for introduction. Respected chairs and also experts online, good morning. Next, on behalf of our center, I would like to introduce the diagnosis and treatment sharing of these 4 cases of adult neuroblastoma. First, female, 20 years old, and was this paroxysmal chest pain, back pain with weakness of both lung layers at 6 months of pregnancy. Paraplegia with incontinence after serration section at 9 months of pregnancy, and CT showed intraspinal malignant tumor in right posterior median stadium and T7 level, lymph node metastasis in median stadium, and the left supraclavicular fossa in other places. Here for the NSE 182 and VMA 151.13. Well, for the imaging, this is the right posterior median stadium and T7 level lymph node metastasis, and also the metastasis in the brain, and also multiple metastasis in the bone. Now here for the biopsy, it says this is multiple bone, it is a ganglion or neuroblastoma, and the GD2 is 22% positivity. Now here, according to the CCCG MB 2009, it is INSS phase 4, high-risk group, and then the treatment course. So because the adult patients, it is not well tolerated for chemotherapy, we have a de-escalating chemotherapy treatment. So firstly, according to the median risk criteria to do the chemotherapy. So after 2 to 3 months, we do a re-examination, and then the patient it's a very well tolerated, and then we do an escalating treatment with the OPEC and OPAC. Now here during the treatment, we observe also the patient is well tolerated. So we just adjusted the high doses for the high risk A and high risk B protocol. So after 9 cycles, the patient reaches PR, and also here has recovered the sensory function of the lower limbs, so muscle strength grade 3. So here we have the minimal residue lesion for the bone marrow. So for the CT showed for the shrinking of the primary tumor, and also the lymph node lesions have shrinked. Also with the lesion in the brain. So this is the before and post treatment for the CT imaging. This is for the bone before treatment, after treatment in the ECT. So here for the case 2, because after the 10th cycle of chemotherapy, there is the infection with the neutropenia. For this case, finally died. For then the second case, female 39 years old. The MRI showed a mass in the right posterior supral median stadium measuring about 5.4 times 1.7. So the out-hospital surgery was this resection of both the primary tumor. So then there are 2 positive lymph nodes and 50 grays radiation, and in the right part, and 60 gray in the right supraclavicular region. So this is the recurrent case after the surgery. So we should see the NSE and VMA. So here.
We also have the biopsy on the right supraclavicular puncture, and also that's metastatic the MB. And also we wanted to have the molecular biology, but the family denied it, so we didn't have that kind of testing. And also that's negative for the bone marrow infection. And we also have this kind of the staging, and that's a high risk patient. And also we have the OPEC and OPAC for the alternating chemotherapy. And during this interval, we also need to recheck the changes of the lymph node on the right supraclavicular part through this ultrasound. And we didn't see significant change in the first 3 cycles. And in the 4th cycle, we had increased the intensity. And also we switched to irinotecan, but then there was a lot of the GI side effects, so we stopped it. And then the third case, a 29-year-old female, onset of the disease in February 2022, and there was the hemorrhage on the left lower limb, subcutaneous, and also ASCU 65.2. And the PET CT has shown the big mass on the left lobe of the liver, malignant, and is the suspicion, and also the patchy nodes in the liver. So we consider that as a metastasis, and also posterior tail of the pancreas, and also there might be the bone metastasis, and the case 3 PET CT, we can see a huge mass there, and also the lymph node and the lesions in the lymph nodes and the bones. And now we look at the evaluation, the ASCU 65.2, relatively elevated, and for the PET CT, there is the mass in the retroperitoneal place, and also with multiple metastases in the liver, bone, lymph nodes, and also according to the biopsy, retroperitoneal mass. So there is the poor differentiation with the neuroblastoma, and they could see no amplification, no mutation out. And also for this patient, we have the CCC GMP 2021 regimen, and the treatment started from the other hospital in the first 2 cycles. So there is the cyclophosphamide and topotecan, and the third cycle we started with a VIT irinotecan and also the temozolomide and the vincristine, and then already negative in the bone marrow. After that, 4th cycle and then surgery, and also PET CT has shown that there are reduced volume on the left renal gland area, and also some of the reduction of the metastasis in the liver, and also retroperitoneal places. And then our hospital PET CT has shown the post-op neuroblastoma in the retroperitoneal side, and also there are thickening of the soft tissue on the left renal gland, and that's considered as the change after the surgery. And also there is the missing part of the left lobe, and also there are some hypodensity lesions in the liver, and also we consider there is a lymph node metastasis, GD2 negative for the bone marrow, and we have got the stem cell collection after PAC, and then OPEC and ASCT, and then chemotherapy, and that's include the radiation on the primary and the metastasis in the liver. And we had the PET CT at FDG evaluation, that's 0 for the FDG, and for the nodes in the spaces of the vessels. So there are some of the avidity too, in order to prevent that kind of recurrence. We have followed with the chemo. The 4th case, 28-year-old female, onset of disease December 2021, and the presentations are aggravated pains in the right lower limb and ASC 169, and there is the retroperitoneal mass. So then the patient had the resection of the mass on the right retroperitoneal side outside of our hospital. And then PET CT, we can see that post-operation, there is the node in the soft tissue sporadically in the retroperitoneal space, and also there is the metastasis in the bones, and also the VP16 plus the carboplatin. And after the first cycle, this patient get to our hospital, ASCU 24 elevated a little, and the VMA 284.95 mole and or micromole, and that means a little elevated. And PET CT also shown the retroperitoneal mass and also the metastasis to the nodes in the neck and the bones, and also the pathology showed us the ganglioneuroblastoma, poor differentiation, low MKI, no amplification of the MYC, and also we can see there is the positive in the bones. And now let's look at the regimen 2021. That means it's also stage M, and we follow that for the high risk group for the treatment. And after 2 cycles of the chemo, the bone marrow is negative now, then harvest of the stem cell, and then CR, and we have the ASCT, preconditioning also MM regimen, and after that, the chemotherapy. So this is also the CR patient. And in the 4 high-risk patients, the 2 used the CCCG mid-risk regimen. Tolerability is good. And then there is the grade 4 myelosuppression after increasing the density with the very severe GI reactions. And another case have got the different approach. And now let's have a look at the literature review. We can also see that there are differences for the MB in the children and the adults. So the onset or incidence rate, that's about 10 out of 1 million. And for the adults, less than 0.3 out of 1 million. And the prognosis, the adults would be worse, and we can see that the 5-year OS 50% for the children and 15.7% for the adults, and for the MBMIC and rare amplification adults, but only 25% children, and the Atrix and ALK mutations are higher in adults. And according to the MSKCC, the Atrix mutation or deletion will account for 58% and 42% for ALK mutation. And for the MB treatment, there is no standard of care. So there is a lot of reference to the children's regimen, and the GD2 monoclonal antibody have already become a standard treatment for the high-risk group in the MB in children. MSKCC is also exploring the GD2 in monoclonals use, and also some good tolerability. And Director Li Ganglin would love to share with the summary on the 4 cases. So when we look at the 4 cases here in this group, we know that they are young female adults, and the IAIM stage M or 4, and also 2 are primary and middle sternum, and 2 with the primary lesions in retroperitoneal. And usually they have the onset because of the pains from the metastasis. There is the initial diagnosis from the first and third, and the second is recurrence. And for this first, we can say they can be tolerability, and also PR is the result, but there is a bone metastasis, and that elevation is not evident. So then we have increased the density or intensity to the high-risk group kind of chemo, but then there are some infections and septic shock. And then the second case is the radiation, no chemotherapy in the other hospital after 6 months recurrence, especially the node in the neck. And then we also have the radiation according to the intermediate risk group, and that's SD, and then switched to the high risk chemo after 1 cycle, no tolerability, gave up. And then the third and fourth cases are that after chemotherapy, there is ASCT and the radiation. These 2 got to CR, still in maintenance therapy now. And for all the 4 patients, 1 declined the gene testing, and the other 3 got to the genetic testing and make no amplification. 1 had 1P and 11Q mutation. Actually, 1 had an ALK detection, but no mutation was detected because for the tolerability issue in the adults, and we didn't have a lot of experiences in early days. So the first 2 patients, we lowered the intensity. So then we have the chemo according to the intermediate risk, and we notice the tolerability is okay. After intensity is lowered, the chemo efficacy, of course, would be limited. 1 patient had a PR, the other not CR, and also that means that they had some intolerability and progression. And then the other 3rd case have got the first line, second line treatment, and they have got the GPR, and then after the ASCT and the radiation got to the CR. The 4th patient, from the very get-go, we used the regimen for the high-risk group after induction treatment, we got to the CR. So we noticed that the high-risk regimen would be better than that of the intermediate risk regimen. However, there are a lot of the myelosuppression and also the GI side effects. And the 3rd and the 4th case, we can see that they have got the single ASCT, the precondition we used the MM regimen. And for both of the patients after the transplantation, probably within 1 or 2 months, they have already successfully reconstituted their function of their bone marrows, and the CBC also has gained its function, and also they received the radiotherapy, now CR. So for the preliminary observation in the young adults, because most of them are at their 20s or 30s, and then the ICT would mean they are tolerable for them. And for these two patients who got to the ICT, they got to the CR, but 4 patients that did not have the GD2, monoclonal or the other targeted therapies. And next, we're going to discuss the questions. Let's have a look at the screen. And here are the questions, and we would love to hear the panelists' guidance. Thank you. Sure. And we would love to thank our experts from the Tianjin Medical University Cancer Institute and Hospital, Professor Li, and also we noticed that they have given us a lot of the experiences, and the first 2 cases used the intermediate risk intensity, but the efficacy is still yet to be improved, and then they switched to the high risk regimen. And also they had the single ASCT. However, in the high-risk regimen, there is also the issue of the toxicity, such as the GI reactions and also the myelosuppression. But these 2 patients had the CR, so they have got the radiotherapy. We are watching them, and they didn't have the affordability for the monoclonal. So now let's have a look at the questions on the screen. And we have the panelists in the discussion, 3 professors from the US, Dr. Modek, Dr. Coglia, and Dr. Casey. Together with the 6 experts in China, they are Professor Tayana with Tianjin Medical University Cancer Institute and Hospital, Professor Deng with the Yat-sen University, Professor Li with the Tianjin Medical University, Professor Zhao with the Yat-sen University, Professor Zhu with the Yat-sen University, and also Dr. Li with the Cancer Hospital Chinese Academy of Medical Sciences. And that means they are alphabetic sequence of Professor Modek. We would love to hear you first. Thank you.
First question was on MICAN. MICAN is never seen in adults, so I don't think that we need to talk about that much in terms of risk stratification. I think adults are with local-regional neuroblastoma should be treated with localized treatment, knowing that the risk of recurrence as metastatic disease later on in life is very high. So even those adults who present with localized disease will very likely relapse with metastatic disease, or they have at least a 50% chance of relapsing with metastatic disease. But MICAN does not come into play. Second question was about chemotherapy. I think this is a tough one. In general, my approach has been for young adults below the age of 30, we do try to use the same sort of induction chemotherapy. But currently we use what's called a modular approach. That is, after 2 or 3 cycles of chemotherapy, we would reassess. And if there's no response at all, we would change chemoimmunotherapy, for example, with much lower doses of chemotherapy. The older adults above the age of 40 or 45, those patients will really not tolerate chemotherapy at the doses we use. And in those patients, we would try to either use low-dose chemotherapy or ALK inhibitors alone. Third question, I think, was on transplant, and that is a controversial subject where we don't do transplant. But in adults, a case could be made to definitely not do transplant because it's much more toxic in older patients. And I think the final question was on antibody therapy. And currently, we use antibody therapy in 2 settings. One, if patients achieve remission, to keep them in remission. And 2, if patients have not achieved remission with standard treatment, get them into remission, either with naxitamab plus GM-CSF or naxitamab plus chemotherapy. So I'll stop there.
Professor Quick there, please. Thank you.
So I don't think I can really add anything substantive to what Dr. Modak has said. I think that the progress in this is going to be in the systemic treatment. I think the principles of surgery are the same. These patients do tolerate operations, and we can do fairly large operations on older patients. As was noted, however, the older the patient, the less toxicity they can tolerate. So you have to that has to guide you as well. I think that the real progress, I think, is going to be made in some form of targeted and/or immunotherapy in this disease.
Thank you. And Professor Casey, please.
I'll just make a quick line about, just to conclude about the radiation for adults, is unlike some of the other therapies where it actually, might be more toxic to throw certain systemic therapies at the adults. For the adults, they actually can tolerate radiation therapy quite well, and late effects are less, right? The older they are. So I would not shy away from doing whatever radiation therapy that we believe is warranted for the adults. I think that is an aggressive approach that we should continue to use. And we've shown for other pediatric tumors too, when you use radiotherapy with the same principles for an adult like tumor that you have in a kid, you do better as opposed to shying away from less aggressive therapy.
Thank you, Professor Casey. And next, we invited our Chinese doctors to give comments. 我们先请曹嫣娜教授吧。
Okay, thank you, Professor Cao. Firstly, thank you for your introduction. And for these 4 cases, I think, well, I am honored to participate in the treatment of some of the cases. For the first case, I think because this case came to our center at a very early time, this is the first case we treat for the adult and MB. So firstly, we consider, well, for the doses of chemotherapy for children, well, there may be adverse events for this patient. So we just start from the medium risk group. So then we escalated the doses because they not so sensitive to the original doses. And after the chemotherapy, after the MDT of the whole center, here we should see for the bone metastasis is under control, and for the primary, for the median statum, and for the brain. At this time, we prepare for the surgery, but unfortunately, at this time point, there is an infection for this case. So here, I think this is a conservative choice at that time for the chemotherapy. But now we think maybe we will just promote surgery to earlier lines. So after surgery, after the control by the surgery, then we give the chemotherapy. I think the efficacy would be better. So this is a lesson learned. So for the more recent 2 cases, I think for the 3rd and 4th case, both of them, they belong to the high-risk primary diagnosed adult MB. So after the chemotherapy with the children's doses, they are well acted, well tolerated. So I think the previous chemotherapy just received a very good results. So the tolerance of the patients is very good. So there is no delay for the next cycle of treatment. So we just, as our plan, as to the pediatric strategy, we give the ASCT to the cases. So after the transplantation, still very good performance, very good condition, and also continuous CR, and also after radiation. So for the continuous maintenance therapy for adult ND, I think for the previous if the good responses in previous period, if it can be maintained, this is not for sure. So there is a higher risk of metastasis or higher risk of relapses. So for the maintenance therapy, no matter if there is a condition to do the GD2 antibody as the maintenance therapy, we think, well, we should have more proactive, more active strategy for the maintenance therapy. And to these questions, I think to my own personal view, for about the reported adult NB, I think most of them, we see a lot of the M phase. So for the LG, for the risk stratification for the high risk group, for the M phase, well, over 18 months, well, most of the cases, they belong to the high risk group. So for the MIC, if it is positive, there is no much significance. So if there is controversy, well, for the L2 patients, if there is amplification for MIC-N, for the adult MB, if there is no distant metastasis for L2, I think the therapy still gets very good efficacy. So if the cases, the number of cases is very small, so because of this reason to alter or to change the risk of stratification, I don't think there is much meaning, much significance. So also for there are HRX or TERT rearrangement. For these factors, should they also be considered to the stratification system? And also for the transplantation here, I think for the early time, if the patient is well tolerated to chemotherapy for the high risk group, I think transplantation is can be considered, and also for immunotherapy for the time point. Well, I think no, not only for adult, but also for pediatric MB patients. Well, for the early time of intervention, well, we have different purpose of a therapy. Well, if at the early time, the addition of GD2 antibody to reach CR as early as possible. So the earlier we get CR, I think the long-term prognosis would be better. And for the following maintenance, the purpose is to reduce the possibility of a recurrence. So we have different purposes. And also there is an important factor is to consider the economic condition of the patient. So these are my comments to the questions. Okay, thank you for Professor Chao, because you have already participated in all these cases, so you have deep understanding. So next, please welcome Professor Deng Meiling from Sun University Cancer Center. So because in our center in the past decade, we have surveyed all the cases. So we have over 50 adult MB cases. So for the radiologists, they also take part in the therapy of these patients. So please welcome Professor Deng. Okay, because I am a radiologist, so for the MB treatment, we just take references to the pediatric MB guidelines for the protocol, as well as the time point and the dosage. Well, we take reference to the pediatric MB guidelines. So the time points, we just choose so chemotherapy, surgery, or if there is transplantation, so after these interferences. And after that, after radiotherapy, if they're for immunotherapy, well, if there is possibility, the patients will receive immunotherapy. And also we take reference for before the pre and post radiotherapy, we will do this localization of these lesions. So this is the experiences from our center. Well, where we use the dosage of a 21 gray. Well, the upper limit would be a little higher, but we seldom use the dosage higher than 30 gray. And we just noticed that you use the dosage in the Tianjin Center for the second case, the dose of radiotherapy just reaches 50 to 60 gray. So this is a point I have a question. So to what consideration you give so high dose to the case? So here is my comments and questions. Okay, for this patient, because this patient received the radiotherapy in other centers and also did not receive chemotherapy, only the post-op radiotherapy. But after half a year after the recurrence, this patient came to our center. This is a real cases, real condition. Okay, thank you. Okay, thank you for the experts for your interaction. And here I have a question for Professor Casey for adult MB about the principle and also the dose of radiotherapy. It is similar to pediatric MB. Is that all right?
Yes, that's what we do. So we don't have a different dosage. So I don't know why 50 to 60 gray was used in that specific case. That's not what we would use. After, our principles are to use after a gross total resection 21 gray and then 30 to 36 gray if there is residual disease, which it isn't the COG approach. The COG approach actually would do 21 gray for everything, even if there was a subtotal resection, because there was a recent analysis that didn't show a benefit to 36 gray. But I think there's still institutional experiences supporting 30 to 36 gray. So I'm not sure why the 50 to 60 gray was used.
Dr. Casey.
Okay, thank you, Professor Casey, because for this patient, she received the radiotherapy not in the very famous tumor cancer center, but in other centers, not so professional at treating these kind of diseases. So this is the case. So next, please welcome Professor Li Jie from Tianjin Medical University Cancer Institute to have comments. So I will just briefly talk about these questions because for the adult MB, well, the incidence is very low, and we could see here with this cases, well, individualized therapy would be more often happen in clinical practices. This is also the accumulation of experiences during the exploration. So for the following in China, we should have this combined therapy for these part of adult MB patients. And also we should have collaboration across different centers to have this long-term plan. So no matter if the dosage reference and also to de-escalate the dosage, there should be some standards to do. We should have a very good summarize for all these cases and a very good summarize and review for our treatment experiences. So this would be more beneficial for the adult, for the pediatric MB. There are differences in the molecular characteristics for there is seldom amplification for MYC-N, but there is mutation for ALK. So for the genomic testing for the NGS, its importance should be emphasized. For in the patients, these useful tools should be better recommended to the patients and their family members. This will have a guiding significance to the following treatment for the patients. And also for the adult patients, they have a poorer tolerance compared with a pediatric patient. So how to choose the chemotherapy protocol, the regimen. So for younger patients, like younger than 30 years old, for the patients with well tolerance, with better tolerance with chemotherapy, is it a possibility with the pediatric MB therapeutic guidelines? Well, is there a possibility to consider ASCT as a standardized treatment? And for the immunotherapy, because of the limits of the economic condition, well, very few of the cases they can receive the immunotherapy. So consider the minimal residue disease. I think cell transplantation is still a very good consideration. So here for the transplantation, can we have a better and further application and discussion on this point? And of course, for immunotherapy, if immunotherapy for in the adult patient, if there's a broader application, this would be more helpful. But the cases would not be so much. So
when we think about the choice of the HSCT, there might be some help. Thank you very much. Thank you, Professor Li Jie. And next, we would love to invite our colleague, Professor Zhen Zijun, with the Tianjin University Cancer Center. Thank you very much. So today we have been talking about the transplantation as well. Every time when we discuss the ASCT, there are different areas. So when we use the ASCT in the treatment of DMB, I think the role is not as important as before, because right now in the current context, there are the allo HSCT and then they're used in a high risk MB, and for that, I'm not sure whether they are reasonable. I have a lot of questions there because there are going to be a high requirement of the immunofunction because it's going to have a huge hit to the immunofunction. It takes a long time for the reconstitution, and also they need to use the immunosuppression to really fight against the GVHD, and also how to use the GD2 monoclonal for the enhancement of the immunofunction. That's also something causing my questions, and also affordability, and also the cost of the anti-rejection, and also those side effects. All of the costs would be really high, and that would already be close to that of the monoclonal use. So if they have used the allogeneic transplantation, they wouldn't be able to use the GD2 monoclonal therapy if they really give up on this kind of highly efficacious with a low toxicity, but really relied on the high toxicity and low efficacy type of approach. So Professor Modek, this is some of the question. Oh, probably Professor Modek has already logged off, but any other? Professor Modek is still online. Oh, that's great. Yeah, I appreciate it.
Allotransplant is something that we are not looking at, and most people would not consider it, partly because if a patient relapses after allotransplant, really no further treatment can be given because of the need for immunosuppression and the fact that the new marrow is quite fragile. But approaches such as using NK cells or haploidentical NK cells have been tried. The one group that is using allotransplants or haplotransplants is the one in Tübingen. Their data is kind of interesting, but not completely convincing. So in general, our approach has been to reduce treatment rather than to increase treatment so that long-term toxicity can be reduced.
Well, thank you, Professor Modak. Next one is Professor Zhu Jia. Zhu Jia 医生，有请。
Professor Zhu Jia, now you have the floor.
Following up this question, when on the allogenic stem cell transplantation is refractory or relapsed neuroblastoma, exploiting the graft versus yes, we noticed a paper published in JCO here entitled Antibody and Haplo and GD2 and identical cell transplantation in patients with relapsed neuroblastoma. This is the result in paper that showed that 5-year EFS and OS were 40 and 53% respectively.
Similarly,
I want to ask a question for Dr. Merck. What's your plan for the transplantation and combined with GD2 antibody on neuroblastoma?
In this era of chemoimmunotherapy, similar or better responses are seen with antibody plus chemotherapy alone, without having to undergo the toxicities of transplant. So, I don't see really a role for this in the modern era where we are already seeing this type of response with chemoimmunotherapy.
Thank you.
Okay, thank you, Professor. Professor Zhu 因为好的那么下面还有我们最后一位点评的嘉宾。
Right, we have the last commentator,
有请李主任来对上
Director Li. So that was the Cancer Hospital Chinese Academy of Med Sciences. So thank you very much for your invitation. I used to be working with the Beijing Children's Hospital, and last year I was then moved to the Cancer Hospital Chinese Academy of Med Sciences. And then I started to see some of the patients at the age of 10 or some adult NB patients. So it's really tricky because when we look at the 4 cases, as we have discussed a lot already very comprehensively. So I believe that for especially the older adolescent or the adults protocol of the treatment of the NB, I would think that the previous guidelines need some amendments because we also have some of the new therapies coming to the landscape. So with the Director Zhang's leadership, for example, we could have some updated guidelines, especially for the older adolescents or even the treatment of the NB for the adults. And on top of that,
Doctor, just now you mentioned that you are not recommend for a checkpoint therapy for neuroblastoma here. There is no responses. There's no recommendation
for checkpoint inhibition.
But so here, in research need Maya trial for colonal tumor, the use of temozolomide, the treatment after the use of immunocheckpoint therapy get good responses. So yeah, 我的问题就是说，如果我们对于这
my question is that while we look at the elderly adults, that means the adults actually, well, after the temozolomide and then the ICI, can that enhance the efficacy? I don't know if there are some relevant clinical practice or experiences that also earlier you mentioned that for the ALK inhibitors. And I was thinking because for the non-small cell lung cancer or this type of the tumor, after TKI is used, it can also enhance the efficacy of the ICI. So I would love to ask for TKI and the temozolomide after the use of that. Can we ask the patients or put the patients on the ICI? For example, the PD-1, PD-L1 monoclonal antibody, or actually there's a kind of the dual IO treatment? Thank you.
I think one of the issues is that we can look at the tumor, right, to give us some clues. Right? The tumor does not have any of these checkpoint markers to give the checkpoint inhibitor would be futile. So I think there has to be at least a biomarker for us to hope that such an approach will work. So for example, if you can show in a patient's tumor that by giving them, say, radiation and temozolomide or TKI plus temozolomide plus radiation, you are actually eliciting class 1 molecules on neuroblastoma cell surface or PD-1 or PD-L1 molecules. If there is a rationale for it, I think that's certainly something to think about. But even in those rare tumors where, say, the based on sequencing, tumor mutation burden is high, or there is instability, even in those patients, the anecdotal patients that we've used based on biomarkers, we still haven't seen responses. So I'm skeptical for a very cold tumor that unless you find a very good way to make it hot, immunologically hot, that these approaches will work. So if there are strong preclinical and clinical data to support it, I think such a trial should be considered. But in general, for all pediatric tumors, the checkpoint inhibitors have not been successful.
Thank you very much.
Now, today we are out of time. So now let me give a new remark. So thank you all the presentators and panelists for the excellent discussion of these patient cases. We learned a lot from this international multidisciplinary team of medical oncologists, oncologicians, radiation oncologists, and pathologists from China and the US. We can see many communities and yet differences in the way that the patients are treated in China and the US. I wish I will have all of you in the future in a hospital to participate in every one of my patient case. I believe not only myself, but also my patients will like it very much for the benefit of this excellent global multidisciplinary team of doctors. In the future, I would like to invite Dr. Modak, Dr. Quigley, and Dr. Casey to visit China and attend the meeting here in China in person. I also want to thank all our Chinese presentators and the panelists from Tianjin Cancer University and the Sun Yat-sen Cancer University to participate in the global academic changes of mind. Finally, I want to thank all the attendants of this webinar for your interest in neuroblastoma multidisciplinary treatment. And thank you so much for the Cyclone Company, and we look forward to the next series of Neuroblastoma International Communication Series. Thank you so much. And thank you, Professor Zhao, Professor Yang, and thank you, Professor Modak, Dr. Quigley, and thanks to Casey and all of participants. Thank you so much. And Professor Zhao, could you give us some words? 赵院长在线上吗？赵教授可能这会儿有另外的一个。
Probably Professor Zhao has another meeting.
I can wrap up. I just want to say thank you to the organizers and to the physician community in China to really share their experience, and it's something which we can all learn from. I thank the organizers, which is eChina Health, for organizing this conference and for future conferences, I'm told, which are going to take place in at ASCO and at AACR and at SGO, and you are encouraged to attend these. And then finally, this is a ASCO breakthrough that's being highlighted, where which is ASCO Asia, I'm told. And then finally, we thank Cyclone for organizing this seminar. So with that, we'll come to an end, and I hope we can continue our collaboration as we go on forward. Thank you.
Thank you so much. Let's see. Bye-bye. Thank you.
Bye-bye. Thanks.
Thank you so much. Thank you, Cyclone. 感谢赛生公司，感谢各位专家
谢谢，
拜拜。
谢谢。
And thank all the experts.
生命是一场探寻幸福的旅程，一次欢聚给予我们青春不散，一见钟情给予我们一生守候，一路陪伴给予我们圆满幸福，一次心声 给予我们更多爱的延伸。感谢生命的给予，一路如影随形，一番旖旎风光。但谁来给予生命悉心关照，为它阻挡风雨，铺洒阳光？赛生医药秉承以患者健康为己任的崇高使命，给予生命更多关爱、帮助及慰藉。立足中国本土，融合全球智慧，坚持自主研发与引进国际品质并行的服务理念，只为造福更多患者。同时，普惠中国及全球其他国家，让生命公平享有高质量的医疗服务和产品。以研发解码科技奥秘，以创新探索医疗未知，以严格质控体现价值，以卓越见证每一步飞跃。赛生成熟而充满智慧，让医疗释放持久能量，给予生命拥抱新生的力量。赛生年轻而充满活力，专注于重大及特殊疾病领域，给予生命重燃希望的可能。赛生更理解生命对健康的渴望，更懂得生命无法承受的病痛，更明白守护生命所肩负的责任和担当，更有能力给邂逅意外的生命以充盈生机的希望。赛生给生命以希望。